and thank you all for being here today. Let me share the screen and let's get to talking about what we know about cannabis and cannabinoids for Parkinson's and movement disorders. So I apologize that my slides today are going to be a little bit generic, but we will cover what we know. So I think that I can skip much of my self-introduction here, except to say that I think that my background is actually fairly conventional, and it was through my years of work at the VA that I got interested in cannabis and cannabinoid medicine. Certainly back in 2011, when Massachusetts started talking about medical cannabis for the ballot referendum, I, like most everybody else, said, medical? Huh? What are you talking about? But I also recognized that in my role as an emergency room physician, I had seen really countless veterans harmed by substances. And frankly, when I say substances, I really mean alcohol. And yet had never seen anybody sick from cannabis. And that led me to think, well, you know, there's got to be a difference in the safety profile here, at least. So if people are starting to talk about using this as some form of medicine, I should probably look into it. And that led me to a deep dive into the literature. At the time, we can remember that there were politicians running about saying things like, well, I would support medical cannabis, but there's no data. And even back then, that was very much not accurate. And if you went at that time to PubMed and put the word cannabis or marijuana into the search bar, you would get a measly 25,000 studies back. Now, clearly, not all of those studies were well done, but imagine, if you will, what it was like to try and wade through 25,000 studies and make some sense of what we know and what we don't know. And that's actually exactly what I did. And I came away from it with the impression that cannabis and the cannabinoids contained in it could be used as a medicine. And like all medicines, it's really about the attention to the dosing and the timing and the use cases that allow us to maximize the benefit and minimize risk. From there, I started my private practice, inhaleMD. I often say I never expected or was interested particularly in being in private practice, but that became the vehicle for taking care of patients in the face of the federal ongoing prohibition, and also allowed me to come back and talk to people like yourselves. As mentioned, I formed the Association of Cannabinoid Specialists along the way, really to try and elevate the standard of care for patients. This is something where we still have a long way to go, and also to make sure that we're properly educating the people who are practicing this kind of medicine. And just as a moment, I have no conflict of interest to report. When we start to think about using cannabis for patient care, we need to think of this in sort of two separate buckets. We need to think of it as in symptom management, and then in a later slide, we'll talk a little bit about disease management. Because our focus is today on Parkinson's and movement disorders, I'm going to sort of lead with the headline here, which is that, you know, if you go to YouTube and search up cannabis and Parkinson's, you will find a small number of very impressive looking videos in which patients start with a very pronounced tremor, and then they smoke a bowl of some weed, and all of a sudden their tremor is completely resolved. And it's very impressive looking, but the studies that we have really don't support whatever it is that's going on in those videos. And I think that many of us are left sort of scratching our heads as to what is going on in those videos that look so convincing when we have an array of studies that basically show that cannabis is not particularly effective for the tremor associated with Parkinson's. On the other hand, as Dr. Simon mentioned briefly, we know that there are a whole bunch of other symptoms that go along with Parkinson's where cannabis can be extremely helpful in elevating quality of life. So first on my list here is pain. Thankfully, pain isn't a major constellation for Parkinson's patients, but we can certainly say that cannabis is useful for pain management, that in most instances, we have very few options for the treatment of pain. Once we get past acetaminophen and the various non-steroidals, we're sort of left with gabapentinoids, which we can sort of discuss whether or not they're truly effective. And then we're sort of stuck with opioids. And obviously opioids come with a certain amount of risk associated. So if we can introduce a medication or series of medications that provide less risk and sort of equal efficacy, then that would be a good thing. And that's really where cannabis comes in. What we've seen is that for mild to moderate pain, cannabis is as effective as opioids with significantly lower risk. That is not an either or proposition, that patients can be using cannabinoids and may also, in addition, need some amount of opioids. But what's interesting is that we need a whole lot less opioid when we're using cannabis in conjunction. And in a number of series, we've seen between a 40 and 80% decrement in the amount of opioid needed in patients who started on opioids alone. So that's kind of pain in a nutshell. Anxiety and depression certainly is a feature of most chronic illness, and Parkinson's is no exception. We also have to acknowledge that many of the medications that we use, like L-Dopa, can provoke some anxiety, and so Parkinson's patients may have an additional and unique need here. Cannabis is effective for anxiety and depression, but it's important for us to know that there are some caveats. One is that it's not a particularly powerful antidepressant and anxiolytic. And so if patients are just starting out, it may be a reasonable choice, but that its efficacy may ultimately be insufficient, and then we may need to add other conventional medications, such as the SSRIs. And again, this is an area where these substances play nicely together, and so we can use them simultaneously. And in fact, as you all well know, the SSRIs, for example, do come with some baggage of their own, in particular issues around sexuality and around feeling sort of well, people say that they have blunted affect, meaning that they feel sort of like a zombie, that yes, their depression and anxiety is better, but they still don't sort of feel like themselves. And interestingly enough, adding cannabis can kind of ameliorate some of those side effects of the SSRI so that they're a good combination together. It's also important for us to understand where cannabis facts and cannabis myths intersect. And this is one of those areas, and this is a repeating theme that we're gonna talk about today. If you ask our cannabis using friends how to treat anxiety, you will get a response that essentially says, before you get out of bed in the morning, you smoke up a big bowl of weed, and anytime you feel anxious throughout the day, you continue to do so. And we know that that's in fact not a very good approach. Not only do we know that cannabis, when used in the daytime, can decrease school and work performance, if that's still an issue on the table, but we also know that excessive use of cannabis can actually provoke anxiety and worsen depression. And so appropriate use of cannabis is really important to make sure that this doesn't backfire. So in fact, what seems to work is small doses of cannabis given typically in the evening or right before bed. And interestingly enough, this provides a pervasive relief from the symptoms throughout the next day, even though the intoxication, which is what everybody tends to focus on related to cannabis, has well dissipated over the course of the night, which really to me demonstrates the fact that it's not the intoxication that's particularly beneficial in this case, but rather that the ingestion of these cannabinoids is altering our brain chemistry and providing the relief from the anxiety and depression. Again, insomnia is a common secondary feature in movement disorders and Parkinson's. And I think of all the things that cannabis can treat, this is the thing that it does best of all. As you're well aware, insomnia comes in a number of different flavors. There are people who have trouble getting to sleep. There are people who have trouble staying asleep, and thankfully a rarer group of people who have trouble with all of the above. Cannabis can address all of these issues, but the way in which we administer the cannabis and the dosing varies with that sort of those differences. Anorexia, and by this I do not mean anorexia nervosa, but rather the clinical term for difficulty with appetite, is something that we can stimulate with cannabis. It's something where we don't see a lot of other conventional options. Certainly we see this also with nausea and vomiting, typically associated with cancer chemotherapy. These things aren't directly related to our topics for the day, so I'm just going to sort of move quickly past that. And just also just touch for a moment on sexual dysfunction. As we all know, sexual dysfunction is a pervasive issue that is inadequately diagnosed, discussed, or treated in the general population. And it's certainly something that presents even more so amongst older adults. And we have very little in the way of therapeutics beyond the Viagra type medications, which only work for men and only for erectile dysfunction. It turns out that cannabis can be useful for all genders and across a wide range of sexual dysfunction. And I think I'll leave it there. And if people have questions about that, then we can talk more about that at some point. Now, we talked before about how we were addressing symptoms, and when it comes to addressing the underlying disease state, this is another area where there's some conflict between what we know and what gets said in public. The reality here is that all of the cannabinoids have been shown to be antioxidants as well as anti-neoplastic at the level of the test tube. But the real question is, what does this do for human beings, you know, in a real world setting? And there's really very little evidence at this point to suggest that any form of cannabis or cannabinoids are ready for prime time when it comes to trying to treat the underlying disease or slow progression of neurodegenerative diseases. That being said, I think that there are a number of very interesting studies, particularly in the mouse model of Parkinson's, where they have been able to show that using various cannabinoids, including both THC and CBD, we've been able to retard the progression of the disease. So I think there's a lot more interesting stuff to come about that. But when it comes down to what should we be doing for our patients at the moment, I think we need to be focusing on those symptoms and really are not in a position just yet to be talking about cannabinoids as a disease-modifying treatment. The next couple slides are the ones in which I try to address some of the elephants in the room. I think that it's important for us to understand both our sort of inherent concerns and the realities of the situation. So the first is, isn't cannabis addictive? And the first thing I would say is, listen, we have to remember that addiction and dependence are not the same thing. That dependence is a physiologic condition or situation in which our bodies habituate to a substance and then present us with withdrawal symptoms if we stop this. And this is something that we can see with cannabis. Thankfully, it's not very common. We'll talk more about that in a second. Addiction, on the other hand, is really a set of maladaptive behaviors that arise around the use of a substance. And thankfully, we don't see that very much in the cannabis space, particularly when we're talking about treating patients. It's not impossible. It certainly can happen, is defined as cannabis use disorder in the DSM. But I think that overall, we don't see it as much as we hear about it, and this is somewhat reassuring. When we want to put the risk of dependence into some perspective, we can compare it against other substances that are either used therapeutically or freely available in our community. And we can see that there's a lifetime risk of dependence of about 7% in cannabis users. And we can compare that to about 32% for nicotine, in the mid-20s% for opioids, about 18% for cocaine and benzodiazepines, and about 15% for alcohol. So you can see that the risk is real, but that it's about half that of our lowest other comparator here. The other thing to know is that unlike these other substances that I've just mentioned, the risk of cannabis is front-loaded. And what this means is that the risk is higher for teenagers and young adults, who then have a risk of roughly 18%, sort of in line with the benzos and the cocaine. But if our patients have made it to the ripe old age of 25, then that risk drops to about 2 to 3%. So hopefully all of our patients with Parkinson's have made it to these august ages, and we have even less to worry about in terms of their dependence risk. The other thing I think is important is to say, okay, now we know what the risk is, but what does the actual withdrawal look like? Certainly we're well versed in the vicissitudes of opioid withdrawal, and thankfully cannabis withdrawal is nothing like that. Cannabis withdrawal is a non-lethal event and is typified by about a week of insomnia and mood instability or irritability. Of course, those two things may very well have been what we were treating in the first place, so sometimes it's a little bit difficult to tease that apart. The other issue that comes up are around cognitive health, and patients often ask me, yes, doc, but is this going to make me stupid? And the short answer is no. We have decades upon decades of studies now looking for cognitive harms using a variety of approaches in recreational users, including IQ tests, MRIs, and fMRIs. And it's important for us to understand that these studies are all slightly flawed in that they use recreational users as the test population, and also are by and large what we call BYOC, meaning the studies were done by asking the subjects to go elsewhere and kind of do whatever they were going to do and then come back for the testing. So there was really no control over the dose and other factors. But we do know that generally speaking, recreational users use more cannabis than our patients. And the best studies today have really shown only about an 8-point drop in the IQ function in verbal memory only, and have shown no changes in executive function or spatial and quantitative function. And these were only seen after about 20 to 30 years of heavy use as defined by those studies. So generally speaking, that presents some risk, but it is otherwise somewhat reassuring in terms of the magnitude and also the time course. But I think for us, the major question is, all right, but those were recreational users. What do we actually know about what it's going to do for our patients? And we're now starting to see studies come along that look at patient populations, the best of which were done at McLean by Dr. Stacy Gruber. And what's really interesting there is that they've actually shown net cognitive improvements. And you say, well, how can that be? And I think the best answer is that being sick causes significant cognitive impairment, and that when we use cannabis, we can make people feel better. And so the net result is that their cognition improves. Nobody is suggesting that this is taking people back to their cognitive function at age 20, but rather simply that by ameliorating their symptoms and improving quality of life in their current situation, that we get a net benefit. Come on, cursor, where's the, oh, well, that worked. So let's just talk a little bit about how we use cannabis for patients. And like all medications, the route of administration is really crucial to having it behave in the ways that we want it to behave. I think that most people, when they think about cannabis, immediately start to think about smoking. I generally don't recommend smoking to patients because we think that smoke is probably not very good for us. As an aside, the literature on the harms of smoking cannabis really are not in line with the harms of smoking tobacco. In fact, in 1981, a pulmonologist at UCLA, Dr. Donald Tashkin, started a study with a bit over 1,000 recreational users and has been following them since that time, looking for the development of COPD and pulmonary cancers, and really has not found that to be the case. Nonetheless, we do know that cannabis smoke contains many of the similar sized particles and toxic chemicals that we find in tobacco smoke. And so generally, it is my view that since we can avoid smoking in this situation, we should. Why are we talking about smoking at all? And I think that that's an important point, which is that smoking is one not very good approach to a broader category of inhalation. And inhalation does turn out to have important therapeutic uses in the cannabis world. And so if we're not going to smoke, then what we need to be looking at is vaporization. Vaporization comes sort of in two flavors. In the middle of the slide, you can see this sort of orange vape pen, which I often call a vape pen or an oil pen to distinguish it from the flower vaporizer that I'm going to show you in a second. But the problem with those vape pens is they're completely unsafe. They're not very sophisticated devices. They tend to combust the oil so that we're inhaling those toxic products of combustion. And more recently, we have data that shows that the actual cartridge, the metal in its construction, can leach heavy metals into that oil, and those then are volatilized and inhaled. So generally, I recommend against those vape pens. They're ubiquitous and easy to use and cheap to buy. And so that from a public health point of view, gives us a little bit of an uphill climb trying to steer our patients away from those. On the other hand, we have this device above the vape pen with the little spout and the fins, and this is an example of a flower vaporizer. Flower, in this case, I want you to think like roses. It's the flower of the plant. When we talk about weed, it's actually the flower of the cannabis plant that's dried and ground up that we use as the substrate for our treatment. And so these devices are the appropriate technology, and what makes them different is that they actually have a little microprocessor in them that is using a continuous measured temperature negative feedback that allows us to set the temperature and maintain the temperature. And the temperature that we ideally want to hit here is 350 degrees Fahrenheit. I always say, just like we were baking cookies, because at that temperature, we volatilize all of those cannabinoids that we want, but we're not causing any combustion and not deriving any of those toxins. Above 350, we don't get really any additional benefit. And when we hit 400 degrees, we start to make some benzene and other carcinogens that we want to avoid. So the mainstay of treatment are these sorts of devices that give us that kind of control and specificity. So why are we interested in inhalation at all? And the answer is because when we use cannabis by inhalation, it's rapid onset. It works in 10 to 15 minutes. It's important for our patients to know that on the internet, people will say it's immediate or instant, and that's not true. And you can certainly take way too many puffs on your vaporizer in the 10-minute period. So we have to warn them about not overdoing it in that regard. But it is rather rapid, and that is important for certain kinds of illnesses where the onset is either episodic or very acute. And the example that I typically give is a migraine type headache, where we know from the neurology literature that it is best for us to intervene quickly before it gets out of hand and becomes much more resistant to treatment. The other thing that's nice about inhaled cannabis is it wears off relatively quickly in sort of about 3 to 4 hours. So if we have managed, for example, to treat that migraine headache and it has now gone away, we'd like the effects of the medicines to go away as well so that our patients can get back to life. That's sort of inhalation in a nutshell. Certainly, we've heard lots and lots about edibles and gummies in particular, and it's important for us to understand that these are also valuable for treatment, but that they're very much the opposite of inhalation. Where inhalation is rapid onset and relatively short duration, the edibles are slow to work, kicking in about an hour, but sometimes even slightly longer than that. But once they do work, they work for longer, more like 8 to 12 hours. And so we can think of the inhalation as our immediate release medicine, and we can think of the edibles as our extended release medicine. And this makes them much more useful for people who have chronic pain, for example, where the pain is 24/7, and we want to be able to get a nice, steady, controlled level of pain management using something with a nice long duration like those edibles. There are a few other approaches out there that I want to just briefly touch on. There are tinctures, which are a liquid form, and I tend to recommend staying away from tinctures. They're incredibly popular. I think people like to dabble with them, and there is this idea that you're supposed to put it under your tongue and that the cannabinoids will be absorbed sublingually. We actually know that that's not true, that there's no absorption, and the best we can do is sort of trigger some sort of Pavlovian response doing it that way. But frankly, they only really work when you swallow them, and then they're really the same as the edibles that we just talked about, except that as a liquid, it's very easy for our patients to make mistakes with their dosing, and that's really the primary reason why I recommend staying away from them. I will use them in certain cases where patients have allergies to the medications or ingredients in the edibles, and I certainly used it in patients who have G or J tubes where we need to be able to put the cannabinoids down the tube. And then there are cannabis topicals, creams, lotions, and patches, and that sort of thing. And sadly, I have to say that these don't work. They're very expensive, but we know that the cannabinoids will not pass through the dermis, and so they may be valuable for the treatment of dermatologic issues. But if we have pain, in the back or in the knee or some deeper structure, that rubbing cannabinoids will provoke a strong placebo effect, but will not actually contribute, medicinally to the benefit. And because they're so expensive, I tend to recommend that we stay away from them. Dosing is the key with every medicine, isn't it? Right? And cannabinoids are no different. And like every medicine, as we increase the amount of the medication, we arrive at what we might call the sweet spot, which is the range at which we're getting the maximal benefit with the minimum of side effects. And I should mention that, when we talk about cannabis in a recreational fashion, we're really talking about the intoxication as sort of the main driver of interest. But for patients, intoxication is a side effect and one that, generally speaking, we'd like to avoid. And so, again, the dosing becomes critical for that. In my clinic, 10 milligrams seems to be about an average dose. This is vastly below what we see people using in the community, and in particular for recreational uses. So our goal with our patients is going to be advising them on how to use this safely, and we really don't want to be sending grandma home to be doing bong rips. Another area where the mythology is important is about talking about the different types of cannabis and also a little bit about CBD. There are over 7,000 different named and listed types of cannabis that are called strains. They truly should be called cultivars, but strain is the word that gets used in the community. And the cannabis industry very much has a vested interest in people believing that these various different types of cannabis have different effects and will be differentially important or valuable to the treatment of the illness. And the reality here is the scientific literature shows that these strains are largely the same in terms of their chemical composition, and that there's no discernible benefit to the differences. And so we can be much more straightforward and simple about this and think about cannabis sort of in a more unified way. There is some very interesting preclinical work being done in the oncology field that is showing differential responses to different cannabinoids, some of which may or may not be represented more or less in different amounts in these different strains. But this is all very preclinical and certainly has no place in our clinical work just yet. It's also important to know that the cannabis community tries to divide these various strains into categories called indica on one hand and sativa on the other, and hybrids in between. And again, this is an attempt to sort of classify them into categories that prescribe their different effects. But what we find is that this doesn't hold any water, and that chemically there's really no distinction. And so we need to move beyond these kind of lore-based appellations and really get into focusing on what we know about specific cannabinoids. And that information is evolving, and much of it is yet to come. One of the areas where this has come up, of course, is the role of CBD as opposed to THC. CBD has become ubiquitous because in 2018, the Farm Bill made hemp and its chemical derivatives, including CBD, legal to sell. And it's become a great product to sell. It's not quite such a great product to use. We see that in preclinical studies, CBD can be useful as an antioxidant, as a neuroprotectant, which means that at some point we may gather more data that says that CBD is in fact useful for the treatment of underlying disease in neurodegenerative illnesses like Parkinson's, but we really don't have that evidence at the moment. Furthermore, the evidence that we do have, which is largely derived from the treatment of children with rare genetic seizure disorders called Dravet's and Lennox-Gastaut syndromes, show that we need to use CBD in vast amounts, about 10 to 20 milligrams per kilogram, which is easy to achieve in a small child and much harder to achieve in an attacked adult. And furthermore, when we get into dose ranges like that, we start to see that CBD can interact far more than other cannabinoids with a whole range of potentially harmful conventional medications, as well as potentially stimulate some direct hepatotoxicity. We'll talk a little bit more about that shortly. Well, okay, now is shortly. So these are the medications that we found people were looking up on Google and looking for interactions. And as you look at these charts with me, the important thing we're looking for are these red Ys. So the N means no interaction. A T, like you can see here in the THC category, means that there's the theoretical interaction, but actually we don't see any particular problems arising. And so we can see amongst the ones that concerned patients, there's really only an interaction between CBD and esomeprazole, and that's not a particularly concerning interaction. On the other hand, on the right-hand column are the medications that I was concerned about, and you can see that there are far more red Ys in this category. This includes things like amiodarone, tacrolimus and everolimus, lorazepam, and warfarin, all of which are potentially harmful if we get them outside the therapeutic window. Also want to point out that on this list is good old loratadine or Claritin, which obviously is over the counter. And this, I think, is a disaster sort of waiting to happen, because as you may remember, excessive amounts of Claritin can lead to sudden cardiac death, and that we would like to avoid. Another area where the system is imperfect is this idea of certification. Unfortunately, we cannot write a prescription for these medications at this time, and that really hampers us in a whole number of ways. The first is that people get very focused on getting their card. which is lovely because that does provide access to the cannabis medicine, but it really isn't sort of the end game. Obviously, what we really want to be doing is providing effective and safe medical care. And this requires, like in all fields of medicine, time spent by the clinician with the patient to educate, to answer questions, etc. But it's also unfortunate that the card, while it gets the patient into the dispensary, we don't have the ability at this point to be more specific about what sorts of products the patients should get. And as a result, the dispensaries really go out of their way to sell as much product as they possibly can. And this involves providing misinformation to our patients, and often very much contradicting what we have said to the patient. Which leads me to the fact that, at least in my practice, I really spend a lot of time trying to guide the patient, trying to head off some of this misinformation, and then becoming and maintaining close availability for patients so that I can answer their questions and sort of try to keep them on the straight and narrow and undo the issues around the dispensaries chatter. This is just a little bit about the Association of Cannabinoid Specialists. We are really focused on reaching out to clinicians such as yourselves. You can go and visit us at cannaspecialist.org. We have a whole range of resources available to those of you who are curious, as well as links to providers in your area that can help as a specialist with your patients. And we also have some deeper coursework if you're particularly interested in that, including a section on neurodegenerative disorders. And if you're of the mind to actually join the organization, we have even greater resources, including a curated library of studies that are sort of seminal works in this field. This slide is totally irrelevant, and this is my last slide here. If you're looking for references, you can follow that bit.ly link. And if you are looking for articles on the topic that you can present to your patients, we have over 200 articles on my website, inhaleMD.com, that you can send your patients to. And of course, you can always email me at doc@inhalemd.com with any questions, referrals, or patient scenarios that you might have. And so that really is sort of the end of my prepared statement, and I'm eager to answer your questions. So let's get to that.
Thank you very much, Dr. Tishler. Really nice talk with some very interesting and practical information. I know a lot of people are interested. I get asked about this all the time, so I appreciate it as well. There are several questions in the chat. I can maybe read a couple of them. We'll see what we have time for here. One said, I'm not sure when this was placed in the question in regards to which study you were talking about, but it said, aside from dose, what are the other factors that are important to control for in these studies?
That's an interesting question. I think dose is, in terms of doing the studies, the dose is really the major issue. Certainly, there could be some discussion about, the type of cannabis, though, as I mentioned, the rest of the literature doesn't support that being a significant factor. There are, as we talked about, sort of many other ways that cannabis can be administered, so we want to control for that, and that may affect things like timing relative to the study interventions. But really, I think that the thing that's lacking so far has been in that control of dose. And I want to also say that more modern studies, meaning studies from the last 10 years or so, have really gotten around that by being specific about the dose, and even in some cases being able to provide the cannabis material, which obviously gives us the greatest control over what is going in prior to the intervention.
I think there's a couple other questions relating to sort of more specific Parkinson's symptoms. For example, any evidence that cannabis might be used in treating Parkinson's-related dystonia, and another about what cannabinoids help with stiffness and mobility. So they're just asking about cannabinoids and specific Parkinson's symptoms.
Yes, I think that the answer to that is yes. Cannabis can help with all of those, the dystonia and some of the movement issues. Where it's really not so helpful, as I mentioned, is in the tremor control, but I've seen it be useful even in the movement initiation phase and as well. So that's all THC driven. And interestingly, THC kind of gets a bad rap, obviously, because of the intoxication that it causes. But if we can kind of put that aside and acknowledge the fact that all of our medicines come with some sorts of side effects, and that is our goal to, ameliorate those as best we can while getting the benefit, we have to understand that THC has been researched now for about 70 years, and there's remarkably good data on the use of it for things like pain management, dystonia, muscle spasm, etc. And so, yes, absolutely helpful. And again, a little goes a long way, so we really can manage both the symptoms and those side effects.
I have a related question of my own that's sort of a follow-up to that is, I have a lot of patients who use various forms of cannabinoids and feel that it helps, but of course, as you mentioned, the placebo effect's always a concern, especially in Parkinson's, actually, where expectation of reward can cause dopamine release and can truly make them better, which is great, but it makes me wonder. So for some of these features, you mentioned you've seen improvement, but are there placebo-controlled data to show that it works beyond placebo for some of these Parkinson's symptoms?
Not specifically in Parkinson's patients yet, but in generalizing from other types of neurodegenerative disorders, then the answer would be yes. And the neurodegenerative disorders that have gotten the most cannabis research so far have been MS and ALS. And, there are clearly vastly different underlying pathologies here, but in terms of sort of the end outcome, there are some overlaps. And so it's not surprising to me to see that there are similar benefits. To your point about to what degree could we be getting a sort of dopaminergic blast from the cannabis? I don't know. I think that's a really good question. I'm not sure how we would address that, particularly in human beings as opposed to mice. But I think that's a great question. And on some level, as you kind of inferred, if they're getting a benefit from it, they're getting a benefit from it. And so, a lot of what I wrestle with is sort of what is the utility and ethics behind a placebo in the first place? And, my mother, who's a now retired oncologist, said to me at one point, well, what's so wrong with placebo benefit? And I really had very little good rejoinder to that, except to say that in my experience, the downside to placebos is that they are capricious, right? In that they're dependent upon belief. And so if anything comes along to undermine that, then they stop working, and that's unfortunate. So I tend to aim for things where we really have solid evidence for its efficacy. If people are additionally then getting some placebo benefit, so much the better.
Yeah, I agree. I always say as a researcher, placebo effect is a problem, but as a clinician, it's great. Yeah.
Let me just add to this. I've just completed a study with a company, so unfortunately, I don't think this is going to get published, but we were looking at anxiety treatment with CBD, and what we found was 71% of the subjects got benefit from the placebo and no more got benefit from the CBD. So not only was it a failure of the CBD in this case, but it's also striking that 71% would get placebo benefit. That's huge, and maybe speaks to the popularity of this sort of over-the-counter CBD products at the moment. And it makes me think we need a lot more behavioral health specialists out there to help with the vast unmet need for that this placebo effect is kind of tapping into.
Yeah, that's really interesting. Thanks. Another question here. Is there risk of edibles and negatively increasing constipation associated with Parkinson's?
Great question. No, thank goodness. The amount of gelatin in these gummies is tiny, and so it doesn't seem to have any effect on bowel frequency. And the cannabinoids themselves are certainly not constipating, and in fact may actually be helpful for constipation.
Okay, great. Another question they're asked, well, it's a general question about other cannabinoids besides THC or CBD. Do you have any comments about that?
Yes, I could talk for several hours on that topic, and so I will try to encapsulate them quickly, which is to say that there are hundreds of known cannabinoids at this point. What's not known is what are they doing and how important are they? And so right now we've sort of got a good handle on THC, we've got a little bit of a handle on CBD, and then there's all these other things like THCA and CBDA and CBG and CBC, and the list is very long, where we've seen in the test tube that they are antioxidant, anti-inflammatory, and even anti-neoplastic. But again, we really have no idea what this means in human beings. And so, unfortunately, again, due in part to the hemp bill or the farm bill, if you go to California, you can find every one of these available on the shelf, and we really have no idea what they're useful for, and we have very little idea of what their safety profile is. And just as an important aside about the internet is that all of these things can now be ordered online, and our patients are doing so, and they're completely unregulated. Meaning, yes, they're legal, but there's nothing known about their manufacturing and their safety. And we found all sorts of horrible things in these preparations, from heavy metals to pesticides to opioids and benzos. So at this point, these other cannabinoids, we really need a whole lot more research before we know what to do with them. But we also have to be just a little wary that our patients aren't using them anyhow. And if they are, we need to really think a lot about where they're getting them and whether there's any evidence that that particular brand has done the analysis to make sure that there's some purity.
Thanks. Yeah, we have time for just a couple more questions, though. They're still coming in. So
great. I'm happy.
Sure. Is there any benefit for cannabis in mild cognitive impairment? And if so, which forms of cannabis?
That's a very good question, and I think the answer is still unknown. We certainly have seen that patients who end up having some cognitive impairment because of other illness have gotten better. That was a study that I mentioned from Dr. Gruber. I think that as a direct effect on cognitive decline, I would say no, or at least not proven yet. We also know that there's a fair amount of anxiety that goes along with that sort of degeneration. And so we may actually, again, have a net benefit if we're treating the anxiety and that sort of freeing up computational resources for cognitive function. And then, sort of tangentially related, we see that in patients who develop more severe cognitive impairment of Alzheimer's type or other forms of dementia, that cannabinoids can be useful in terms of treating the anxiety, the OCD-like features, and also to some degree behavioral control when things are really fairly far gone.
Thanks. Like I said, there's a few other questions I think we won't get to, but one last one, which I expect is on other people's mind, having heard you talk, which is Dr. Tishler seeing patients and prescribing or just running studies?
Actually, running studies is the smallest bit of my life. I spend most of my life doing clinical medicine, and then running this not-for-profit, the Association of Cannabinoid Specialists. So yes, I am here and eager to help you guys with your patients. And the easiest thing to do would be either to email me directly, again at doc@inhalemd.com, or go over to the website, which is inhalemd.com, and there's an intake form that patients can fill out, and we can get people in to be seen actually rather quickly at this point.
Great. Thank you once again. A really, really interesting talk. Lots of important topics. I expect, a few years from now, it'll be great to have you back with what I'm sure will be important updates.